Good morning. It's a beautiful day in Minnesota. The sun has finally joined us here. My name is Angelina Barnes, and I'm the Executive Director of the Minnesota Board of Psychology. I've been the Director of the Board, honored since 2009, and my role is obviously Chief Administrative Officer of the Board. One of the things I get to do that I find very exciting is be the moderator or the host of this annual conference. The Minnesota Board of Psychology, as you know, is designed to protect the public. We do that through licensure, regulation, and education, and this is a key component of our educational programming. We're very pleased that you decided to spend this morning with us and this afternoon, and we're really excited about the idea that today we'll also be building upon and taking actual action and making contributions to the Minnesota Mental Health Workforce Plan. Hundreds of hours and work has gone into creating this plan for the state of Minnesota. Today, we'll build on the work that they've done from a psychology perspective. You'll be able to, later in the afternoon, contribute thoughts, ideas, suggestions, recommendations, all so that we can continue to make the progress and to flow with the momentum that this project has already had. As I mentioned when we opened, I cited the board's mission and the board's vision, which includes being an extensive participant in the educational community and in doing outreach and connecting with our stakeholders. And we believe that this is coming true. We believe that after we began in 2012 with this plan, we believe we'd made significant progress and covered significant ground in developing those relationships and in creating the type of agency we would like to be. That success is attributable to the hard work, resilience, and perseverance of many, not only our stakeholders themselves as we develop those relationships, but our board members and our staff members. Conferences like this, the development of the educational programming, and the other things that we're able to accomplish and offer to the public and to our stakeholders wouldn't be possible without the board and its staff, definitely. I certainly know they make me look good when they're behind the scenes pulling it off. So I'd like to thank my entire team of internal staff members, as well as the Board of Psychology for their contributions. So if we could, just give them a round of applause for all of the work they put in. Thank you. And in terms of individuals who contributed today, we have so many contributors across the entire state today that built this mental health workforce plan. The state plan wouldn't have been possible without the participation of hundreds of individuals, associations, institutions, and state agencies coming together in a remarkable way for collaboration and discussion about one of the state's primary concerns, the shortage of mental health services for the state of Minnesota and how we will meet those demands with our workforce. The state plan also captured insights and suggestions from over 290 forum participants from Worthington to Brainerd to Grand Rapids to Northfield. The individuals and the creation of this plan included personal conversations with people who will make a difference, and their contributions and recommendations will take action because of the efforts of this group. Additionally, an online survey was completed by more than 500 Minnesotans in creating this statewide mental health plan. The level of contribution and participation has been greatly appreciated by the leaders of this project, as well as has impressed the Minnesota Board of Psychology. This is an incredible initiative, and we're so pleased to be able to give it the forum and showcase it today. Out of Minnesota's 11 geographic regions, 9 of those regions are designated by the Health Resources and Services Administration as mental health professional shortage areas. Workforce metrics used to understand access to mental health services include waiting time for an appointment, number of culturally diverse mental health professionals and practitioners, and the time it takes to recruit providers. Primary shortages for Minnesota identified as critical to address in general include the shortages of psychiatrists, prescribers, and our child mental health professionals and adolescents. Even more problematic, mental health professionals do not currently adequately represent Minnesota's diverse population, which is a serious concern and a goal of the Minnesota Mental Health Workforce Plan. Not only is Minnesota on board to make these changes and to take action, but the federal action agenda for the President's New Freedom Commission on Mental Health, 2002, reported that the mental health delivery system can only be as good as the efforts to train, educate, recruit, retain, and enhance an ethically, culturally, and linguistically competent mental health workforce plan throughout the country. That plan couldn't echo more of what the work that took place for this state mental health plan has done and the recommendations it arrived at. The field of psychology faces its own challenges relating to recruitment, education, training, and diversity, and number of psychologists that can be traced to the overarching issues identified in the State of Minnesota Mental Health Workforce Plan. In general, today we're going to examine in greater detail through Mary Rosenthal's presentation what was identified through all the participants and what resulted. According to the American Psychological Association, an article released in 2013, the internship match, as we all know, is extremely problematic for training individuals and for getting them into the practice of psychology. This specific article from the APA cited that for the past 7 years, and this was in 2013, that for the past 7 years, about 1/4 of psychology graduate students who have gone through the internship match program have not secured an internship. Significant progress has been made in that area, and it continues to rise. The match levels are increasing due to the work of the APA and APAGS, the graduate group. Impressive work. While we're pleased with that progress, it's not enough, and it's not enough until we can provide those opportunities to help feed the mental health workforce. The number of students who matched with an internship in phase 1 of the match, sponsored by the Association of Psychology Postdoctoral and Internship Centers, or APIC, has increased. APIC reported that 3,239 students, or 73% of applicants, matched in 2015. One of the steps taken to address the issues identified with internship matching was to advocate and build a toolkit through APA and APAGS so that they could seek, individuals could seek and entities could seek Medicaid reimbursement of intern services. As we know, we have to follow the money. If individuals aren't paid for their services and contributions, it's very difficult for them to continue to give. As you know, even though we make these progress as an internship, there's still other challenges that face Minnesota. The availability of supervisors, along with the costs associated with obtaining supervision, is another frequently identified issue for applicants preparing for psychology licensure. But we're not just talking about dollars, and we'll talk a lot more about this in our focus group and through the information presented today, is there's opportunity cost. There's opportunity cost to the applicant when they don't get licensed, and we certainly have made many efforts in the efficiency and reduction in time and the efforts, but we'll never stop. We have continuous improvement on a day-to-day basis until we can get individuals into the system in the best way possible, and that changes daily. We aren't just talking about dollars, as I said. This opportunity cost to the applicant and to the providers are also cited as concerns. Another primary issue facing the field of psychology itself is inconsistency in the entry-level credentials in both education and in requirements for licensure across the United States. Minnesota is all too familiar with the issues related to entry-level into the field of psychology and the transitions that it's gone through. From master's level to doctoral level is the entrance degree or the terminal degree for this profession. There are issues related to being able to use individuals, their skills, education, and training to the full capacity and to fulfill the scope of what those skills can provide. And there are barriers. We are a licensing board. We believe fully in licensing and regulation for the public protection, but we also believe in partnering and making sure that we aren't part of the problem that's stopping individuals from entering this workforce. And we're committed to continuing to have those conversations to contribute. The educational inconsistencies across the United States raise question about mobility as well. We're going to talk a little bit about technology as a part of this plan, But the ability for psychologists to move from state to state and do so in a timely manner is sensitive. And certainly as we're focused inward today on Minnesota itself, it's also worth mentioning that we need to make sure that individuals coming to Minnesota, that it's easier for them to do so, that they can get here. Currently, the way the law exists, there's a postdoctoral requirement, as we all know, and some of the individuals coming here don't have that postdoctoral requirement or would struggle with licensure requirements. Again, we're committed to talking about those issues and identifying what can be done. The board is prioritized and focused on increased efficiencies in licensures, and we also are looking at how variances to educational requirements can be used but still maintain public safety. Technology solutions, as the world's geographical physical boundaries begin to dissolve, today we need to look at how we can better use technology to provide mental health services potentially with an extremely rural state. Mobility and technology are addressed at a state and national level for psychology. The Association of State and Provincial Psychology Boards, as we discussed last year in our conference, offers an e-passport as a mechanism to promote standardization in criteria for interjurisdictional telepsychology practice. And quoting the ASPPB, they believe the e-passport facilitates the process for licensed psychologists to provide telepsychological services, but this is across interjurisdictional lines, coupled with their initiative to enact a interjurisdictional compact known as SIPAC. I will announce that one of the first states in the United States has adopted SIPAC and passed, so there is one state who belongs to the compact. I don't know if you've ever been in a relationship, but I think that state's a little lonely, so I think we should continue to talk about how that can move forward. For a compact, I think they need a partner state. And so today we're going to focus on some primary things here. This is our next individual that you're going to be hearing from. This is Senator Greg Clausen. Senator Greg Clausen was a serious supporter and advocate for this mental health plan.
Good morning, and welcome to all of you taking part in the Minnesota Board of Psychology 2016 conference. Thank you on behalf of Minnesotans throughout the state for your work on mental health issues. Unfortunately, I'm unable to be with you today due to commitments with the Senate, but I am honored to join you via video as you begin your conference. My background is in education. For over 40 years, I served as a high school teacher, principal, and central office administrator. From my experiences working with students and families in crisis, I became aware of shortcomings in our mental health system. Waiting for several weeks for an appointment and evaluation was commonplace, creating delays in treatment, uncertainty within families, and uncertain outcomes. In 2013, I authored legislation requiring the Minnesota State Colleges and Universities to develop a comprehensive plan to increase the state's mental health workforce at all levels. A steering committee was formed and conducted 20 community forums around the state, surveyed over 500 mental health stakeholders, and in May 2014 held a culminating mental health summit, attracting more than 150 participants. I served on the steering committee and want to thank the more than 30 members for their professional dedication. Today's conference focus on the legislative report, Gearing Up for Action, Mental Health Workforce Plans for Minnesota, outlines 24 recommendations to be acted upon by professional organizations, educational institutions, licensing boards, and the legislature. The conference will provide an opportunity to learn more about Minnesota's mental health workforce needs, review recommendations to address these needs, and identify key concepts critical to the mental health workforce. Much has been accomplished since the report was released in 2015, and yet there is much left undone. I would like to challenge each of you to join me in finding creative solutions to address our mental health workforce needs. Thank you for your ongoing dedication and your work to make Minnesota a better place to live and grow.
Thank you, Senator Clausen. With that introduction, we'll talk a little bit about what will get us to our next speaker, Terry Fritzma. The American Association of Child and Adolescent Psychiatry reports that the national average wait time to see a child and adolescent psychiatrist is 7.5 weeks. That to a family in need, a family in crisis, and a family who needs help now is too long. Minnesota is worse. In Minnesota, the wait time can be longer. Providers reported wait times of up to 14 weeks for an appointment with a child psychiatrist. There is a significant shortage. But it's not only psychiatrists. The state of Minnesota, through its Minnesota Sex Offender Program, has had significant struggles in recruiting individuals to engage at an appropriate level, much so that legislation has changed that would allow either a psychiatrist or a doctoral level psychologist to serve on their special review board panel. There simply aren't enough psychiatrists to go around or other mental health professionals. To further complicate matters, rural Minnesota is facing pronounced challenges related to mental health stigma, low wages, and cost of education and training. So I ask you, what can be done to support the efforts to expand and broaden mental health telemedicine? How can we use technology in training programs and technology-related grant funding to expand telemedicine capacity in Minnesota? How can we reach those families that aren't getting the services, the social support that their children deserve and that their families deserve to succeed? Diversity is also critical. Psychologists are particularly attuned to diversity. We have human diversity as a core component of our educational requirements for licensure. But I was astounded when I saw this statistic. 72% of non-white respondents to the survey conducted in conjunction with the Minnesota Mental Health Workforce identified cultural competence as a critical area, highest priority for education and training, compared to 38% of white respondents. I challenge everybody to continue to consider cultural competence, to give it the priority that it needs, and to recognize and listen to those who are calling for diversity. Obviously, Minnesota needs to improve and expand cultural competency training. Dr. Fritzma is going to share with us today some extremely exciting information, which I will say you are the first group, besides myself and 2 of my staff members, to ever see this data. I'm very nerdy. I'm an attorney at heart, so this data is exciting me. It is about you. It is about psychologists. It is what you told them and what you told us about your field, about your work, about your satisfaction, about your demographics. We can't wait to share it with you, and I know Terry's more excited than I am. Cultural competence needs to be a core behavioral health education and training requirement. So we're going to talk about the responses we got. And we are also going to talk about how will Minnesota increase the numbers of racial and ethnic minorities as healthcare professionals? How do we get them to choose being a mental health professional? And I think we've got a few key suggestions today from what we've seen in some of the data and ways that you can leverage your experience, your knowledge, your expertise to help others see the value in being a mental health provider. The demand for mental health care is predicated on increased strains on the healthcare system. So I ask you, what can psychologists or the field of psychology do to alleviate those strains or meet the demands for this mental health services? And with that, I'm going to provide you with the bio of Dr. Terry Fritzma. If Dr. Fritzma would join us on the stage. Dr. Fritzma is a senior workforce analyst in the Minnesota Department of Health. She collects and analyzes data on healthcare workers and has a special interest in the mental health workforce, and we're glad she does. She provides data and analytical consulting to a variety of mental health-focused legislative groups and task force. Before coming to MDH, or the Minnesota Department of Health, I never like to rely on our government acronyms, Terry was a workforce analyst at the Minnesota State Colleges and University System, and with the Department of Employment and Economic Development. I couldn't think of a better person to share with you these complex and intersecting issues. She has an MA and a PhD in sociology from the University of Iowa. Welcome, Dr. Fritzma.
I'm a data analyst. I'm not used to talking for an hour, so just in case, I'm gonna leave this here. Thank you so much. I am so extremely thrilled to be here. And thank you so much to Angelina and to the board for inviting me. One of the reasons I'm so excited to be here is that I work with a small group of analysts at the Minnesota Department of Health, and we collect data, healthcare workforce data, on about 150,000 different licensed healthcare professionals. And as a matter of fact, we share the data very widely to all different sorts of stakeholders, but I don't believe we've ever been invited to come and talk to the people who have actually provided the data to us. So this is really kind of fun and gratifying for me. So I appreciate being here. Thanks, Angelina. And the other thing is, actually, so Angelina mentioned we just recently conducted a survey, the very first survey we've ever done on psychologists. Could I just see how many of you responded to the survey in the room? Oh. Thank you very much. Which, like I said, we collect so much data, and we sit in our cubes and we analyze it, and we never really get a chance to say thank you to the people who provide the data. We study you guys, so we are quite well aware of the increasing level of administrative work that you have to do, and we know that, for you, responding to a survey is just one more thing that you have to do that adds to your plate. And so we very much appreciate it, and we very much consider ourselves, careful stewards of the data that you provide. So thank you so much. I appreciate that. So here. I'm just going to give you kind of an orientation to my presentation. I want to start with a little bit of background so that you understand some of the context in which this data gets collected and used. And then I'll dive into our data presentation, and it's kind of divided up into two parts. One is looking at psychology, the profession, so what it is that you do, the services that you provide, where you provide them, who you are, and your work satisfaction, which should be fun to talk about. And then the second lens that I'm going to look through is psychology more as a workforce, and I think this kind of sets the stage for talking about some of the issues around the healthcare mental health workforce plan. And I will be this presentation will be fairly data heavy, which for me is kind of fun, but not necessarily for everybody else. And so I do hope to not just bore you with a bunch of data slides, but to kind of weave a story around the data that I'm presenting. So with that, I'll give you a little bit of background. I work for the Minnesota Department of Health, Division of Health Policy, Office of Rural Health and Primary Care, and you probably can't see it, but my group is the Health Workforce Analysis Unit. The organizational details don't matter, but I do just want to kind of give you a sense of the context. So kind of starting from the bottom, my group is the Health Workforce Analysis Unit. We are a small but mighty group of 3 analysts that analyze data, like I said, on 150 different licensed healthcare workers in the state. We survey 17 different licensed professions, and we are adding more all the time. We work within the context of the Office of Rural Health and Primary Care, and what this means for us is that we understand that there isn't just one story about healthcare, particularly in Minnesota. There's at least 2 stories. One about the way healthcare is delivered and organized in more populated areas of the state, and then of course the rural areas of the state. So we're always kind of telling both stories. We're in the Division of Health Policy, which means everything that we collect is actually collected with an eye towards being able to inform policy, not just to collect it for the sake of collecting, which I think government has sort of a bad rap for that. And then finally, I don't know how familiar, I wouldn't expect people to be familiar with the Department of Health so much, but I'm actually really proud of working for the Department of Health. I've worked for, I think, 5 different state agencies in Minnesota, and I want to read you the vision statement for the Department of Health. And that is, health equity in Minnesota where all communities are thriving and all people have what they need to be healthy. And I can tell you that this is a vision that, we don't just talk the talk, we really walk the walk. Every single person, down from, the highest levels of leadership all the way down to, us and even the administrative staff cares very, very deeply about health equity in Minnesota. So making sure that people from all walks of life have equal access to health care, including mental health care, and have better outcomes. So in summary, my group collects and analyzes data to understand urban and rural challenges for the purpose of informing policy and within the context of improving health equity. That's what we do. So, what professions do we survey? Just very briefly, we survey, we are actually legislatively mandated to survey all healthcare workforce, licensed healthcare providers, including folks that deliver primary care, so physicians, physician assistants, all 3 types of nursing licenses. We cover oral health, so the 4 oral health licensed professions: dentists, assistants, hygienists, dental therapists, which is a newer profession in Minnesota. We survey a handful of the therapist occupations, physical therapists and respiratory therapists, as well as assistants. Pharmacy, sorry, this is kind of low. I hope people can see this. Pharmacists and pharmacy technicians. And then finally, this is sort of where my heart is, we collect data on all of the licensed mental health workforce now, including you. So social workers, all 4 of the social work licenses, LMFTs, and then the 3 counseling professions in Minnesota. So that would be the licensed professional clinical counselors, licensed professional counselors, and then the alcohol and drug counselors. And then finally, psychologists. We're fortunate enough to add you all to our list of professions that we survey, and we're really excited about that. And I do just want to mention, we recently revamped our survey so that we could start getting at some of these new and emerging models of care and new, issues that the healthcare workforce is facing. And though we've added psychologists last to our list, you guys are actually the first to hear about your data. You're the very first ones that we've completed the survey for. So kind of exciting. Okay, so what data do we collect? Basic demographics, including sex, race, and age. Race is a big one, and I'll come back to that. We collect data on education and preparation, and particularly for nursing and for mental health, where there are certain job laddering opportunities. We collect not just, hey, what's your highest level of education, but also, are you planning on getting more, and where did you start? So we can kind of get a sense of the laddering in the profession. We collect information on work location, which is how we're able to say where care is actually being delivered around the state. Hours worked, which helps us get a handle more on FTEs as opposed to just, body counts. Your future plans for work, which helps us figure out what our workforce is going to look like 5-10 years down the road. And then finally, we added in our new survey redesign, we've added some questions about some of these new and emerging technologies, like the use of electronic health records, use of telehealth equipment, and then we've added job satisfaction questions, which I must say is, I think, a fantastic addition. We're able to really, really read your responses and get a sense of what it is that you're facing in your work every single day, and I'm excited to present some of that. Okay. So why do we collect this information? It's just very important. I guess I have a little chip on my shoulder. I know that a lot of government agencies collect data just to collect it, and it sits on a shelf. And that's just not who we want to be. And so we do collect it because we are legislatively mandated to collect it. We have a job that we have to do. But if I put that in smaller face font because I want to de-emphasize that. To us, the reason that we collect the data is to make use of it. So we inform specific legislative recommendations. For example, the mental health workforce plan that you're going to hear about actually used quite a bit of our data to inform it. We inform policy work groups. So, for example, last year there was a policy work group that was focusing on how to integrate international immigrant physicians into the workforce. It's very difficult for them to enter the workforce, and so we provided some baseline data there. To support decision-making for post-secondary program offerings. So just a few years back, MnSCU was looking to the scope of practice rules changed for LPNs, and they were looking for how to consolidate and or expand some of their LPN programs, and we were able to supply some data there to help them make those decisions. And finally, can people see those last lines? Okay. Sorry about that. So I will read them. To respond to special requests. And these come in all forms. I think we probably respond to, maybe 10 different requests every month. About half of those come from the media. And we're getting more and more media requests for information on the mental health workforce, which does not surprise me given some of the movement that's happening in the mental health workforce, policy discussions. So I expect that to increase. Okay, let me just dive into some of the details on the psychology survey. As you know, the survey took place at the tail end of April, just into the end of May. We surveyed all licensed psychologists who had a valid email address, because we did reach out to everyone through email in April. We got a 34% response rate, which is 1,270 responses. I know I'm not talking to methodological slouches in this room. I think everybody has an understanding of response rates and the importance of getting a good response rate. And of course, the danger is not necessarily the low number of responses, it's how representative is the group of respondents for the overall population. So I was able to do a little bit of diagnostic work to kind of figure that out, and I can tell you that there were no response differences by gender or by age, so men and women were equally likely to respond, all age groups were equally likely to respond. And we did get a slightly lower response rate from psychologists that have an out-of-state address. So that could have some implications for our findings. But I am satisfied that what I'm going to present to you is more than just, some nice qualitative data. It's actually, safe to generalize some of this. Just diving into some of the findings. Psychology, the profession. So who you are and what you do. Okay, so we'll just start with some simple counts. This might be familiar to you. In Minnesota, there are 3,824 psychologists who have active licensure with the Board of Psychology. And of those, 3,556 actually have a state of Minnesota address. So I'm going to come back to that actually, that's an important point. I also do want to mention that I know that some psychologists are dual licensed with the Minnesota Department of Education, the school psychologists, and also the Board of Psychology here. And for those folks that are dual licensed, they're counted in this number. For people who are only licensed by MDE, they're not counted here. I think that's a relatively small number. So starting off, we do ask folks, what are their psychological specialties? Now, I should point out that you were able to report any specialty that applied to you, so these numbers won't total up to 100. So half of all psychologists, if you can see, reported a specialty in clinical psychology, 34% counseling psychology, and then another third in behavioral and cognitive psychology. And then, we see child and family kind of dropping off after that. Now, I relied on some expert input about these categories. So I would like to actually ask two questions of you. One is, if you could just raise your hands, does this list make intuitive sense to you as a group of psychologists? I feel I see a lot of overlap, but that might not be true. So if it doesn't make sense, or if you see, problems, please raise your hand. Okay. 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 And maybe we can talk about that a little bit in the panel discussion. And as for the rest, does this kind of jibe with your kind of intuitive sense of what the field looks like? Raise your hand if that's true. Okay. Okay. Good. Okay, just some more basic data on the highest degree obtained. This does not surprise me, probably won't surprise you. 67%, about 2/3, have a doctorate or professional degree. 29% have a master's degree, and 4% have a post-master's certificate or certification. We thought it was important to capture those folks that have continued their education after their master's degree. Oh, and I should mention too, I broke this down just to look to see how this changes if you look at folks 55 and older. And even at the age of 55, about 50% of folks have doctorate degrees. So 43% of psychologists own or co-own a private practice. And 65% of psychologists are female. So it didn't surprise me that the field is female dominated, but actually what surprised me was the number of men in the profession, because when I go and look at other mental health professions, they're far more heavily female dominated. So for example, marriage and family therapists are 80% female, social workers are 87% female, and then all of the three types of the counselors, so the LPCs, LPCCs, and LADCs are 73% female. So psychologists are actually the most heavily male of the mental health professions, with the exception of psychiatry. I thought that was kind of interesting. Okay, so I'm going to spend a little bit of time talking about race. So I mentioned that the Department of Health and that our work is we're very much concerned with health equity and making sure that people of all walks of life have access to good care and have good outcomes. So when it comes to talking about workforce, oftentimes that gets translated into discussions about cultural competency. But cultural competency is a very, very difficult concept to define, and an even more difficult concept to measure. So as Angelina sort of hinted at earlier, I think, we can't really expect reliable responses if we ask people, hey, do you feel that you're culturally competent? And so we start off at least with a measure of, the diversity of the workforce. And we really take this pretty seriously. When we redesigned our survey, we consulted with the state demographer's office to try to make sure we're asking about the right mix of races. We allow people to check more than one response, and so these are the results. So about 88% of you responded white, just under 2% Hispanic, Latino, and kind of on down the list. So this is pretty much what we expect. It's pretty much in line with other mental health professions, and actually the healthcare workforce as a whole. So the fact that this group is heavily white, does this mean that psychologists are not a culturally competent group? I wouldn't necessarily suggest that, but we did want to start getting at this concept of cultural competence. And so we asked a question on our survey. I'll read you the question so you can hear how we measured this. Which of the following work or educational experiences best prepared you to work with people from a variety of backgrounds when providing care, sometimes referred to as culturally competent care? And then respondents were instructed to choose just one of these options. So, as you can see, a third of you said informal learning on the job was the thing that best prepared you to provide culturally competent care. And under a quarter of folks said continuing education or professional development coursework. Another, 22% formal educational coursework, formal on-the-job training, 20%, none, 1%. And then some folks have jobs that don't involve culturally competent care, so we allowed them to specify that. What this tells me, this is really interesting because we, in doing this sort of work, care very much about ensuring that our workforce, our mental health workforce, and all of our healthcare workforce is culturally competent and can provide good care. And we often think about the easiest places to make those interventions, like is it in the formal educational programs, or is it in kind of continuing education? And I think those are good options, but I also think sometimes we tend to forget that so much of this learning actually happens on the job, and maybe that's a good place to think about doing some intervention. When we were putting together this survey, we did some cognitive testing and asked people, what does cultural competence really mean to you? And one of our informants said, yeah, it means being able to relate to those stoic Minnesota farmers, And I realized, hey, what we're thinking of cultural competence isn't necessarily what applies to each person on their job. And so I think, it's worth kind of considering where the best place is to put those efforts. Okay. So career satisfaction, I gotta tell you, this was one of my favorite bits of information to analyze. I felt very inspired, actually, and I was kind of questioning, why did I change my college major from psychology to sociology? You guys seem pretty happy. So we asked two questions about career satisfaction. One is, how satisfied have you been with your career overall? And then how satisfied have you been with your career in the last 12 months? 62% of you said you were very satisfied with your career overall. I took a quick look at some of the other professions for which we have data, and you guys blow them away. I mean, you're very satisfied. Now, I don't know, I got to thinking about this and I thought, is this a reflection of your work, or is this a reflection of the type of people that you are? Maybe you just, have great coping skills and know how to be satisfied. But anyway, that's wonderful. And then, we asked, how satisfied have you been in your career in the last 12 months? Now, satisfaction drops off quite a bit in the last 12 months. And we analysts tend to think, well, yeah, that's because of, oh my gosh, all of this, administrative work and, these dealing with insurance and that kind of thing, that's got to be making people kind of grouchy. But it also occurs to me, I'm not 100% sure if that isn't just also partly the way our minds tend to work. We tend to kind of think about, the bad stuff that's happened over the last year, and maybe we just focus on that. And I'm looking at a room full of people that probably have some insights, more insights than I do about that. So maybe we can leave that a little bit to the panel discussion. But I will say this is a pattern, this kind of decreasing satisfaction between overall and the last 12 months that I've seen across all of our healthcare professions. So kind of interesting. But you guys are very satisfied overall. So then we got some great qualitative data. We asked you to spend a little time telling us what are your greatest sources of satisfaction, and then what are the things that really dissatisfy you about your work. And far and away, the the thing that made you most satisfied in your work was your direct client and patient care. One of the things I saw over and over was people articulating, it's just so nice to be able to see people who come into my office really kind of in a state of disarray, and then, they manage to really make improvements in their lives, and that's wonderful. People mentioned, a lot of these are sort of intertangled, but I pulled out some of the themes that popped out. But developing trusting relationships with their clients was very meaningful for people, and they derived a lot of satisfaction. An emphasis on psychotherapy over drugs, which is really timely right now. So that's something that quite a number of you mentioned. A number of you mentioned working with special populations, so immigrants, children, veterans, teens, and severely mentally ill, that gave you quite a bit of satisfaction. Other sources, besides just working with your clients, a lot of people noted that, I took this as being slightly different, but that feeling of appreciation that you get from your clients, and feeling, through letters and through feedback and through word of mouth referrals that, you really, are appreciated and you're doing a good job. You feel that your work is meaningful. We all want that, to be able to go to work and feel like we're making a contribution, and you guys do. And then people mentioned rich collaboration with their coworkers and colleagues from other disciplines. That came up quite a bit. That was valuable to you. More, I actually think people said more about the reasons they were satisfied than the reasons they were dissatisfied. So that's kind of telling. A number of you mentioned how satisfying it is to mentor and train students. A lot of folks mentioned kind of this combination of being able to help people, but also have that intellectual stimulation and that constant, chance to learn. And I got to thinking, I'll bet this is, I don't know how you all feel about the Myers-Briggs. I imagine there might be some strong opinions one way or another about that, but I thought these are people that are, right on that line between the T and the F. So very thoughtful group, and caring. And then a lot of people mentioned the autonomy and the flexibility of their work. And some of you mentioned how satisfying it was to own your own practice. Okay, sources of dissatisfaction. Are you guys surprised? That came up over and over and over. Insurance, it's just a pain. And I tried to kind of separate out some of these different themes. So the pre-authorization, and particularly with pre-authorization, what's disturbing is that you have to work to try to make your case, and you feel that, there's arbitrary oversight that really overrides your own professional discretion and expertise. Reimbursement is a source of dissatisfaction. Many legitimate, activities are not being reimbursed. A lot of people just mentioned in general, like the coding, the billing, it's just burdensome, all this documentation. And many people mentioned how each insurance company does something a little bit different, and so you have to kind of figure out the rules for each one, and that's very time consuming. Other sources, just administrative tasks that are diverting time from your working with clients and being able to do the most meaningful part of your job. This was a big one. Pay is low relative to other highly educated professions. A number of people mentioned, student loan, they mentioned that it actually keeps them up at night to have the burden of all that student loan and having a relatively low paid job. And the reimbursement rates are fairly stagnant, and so that doesn't appear to be changing. Electronic health records, people mentioned some concerns about those. And then just a couple comments about, not as many as I would have thought, but about just feeling burned out and feeling a little bit helpless over time in the face of all of these kind of heavy problems issues that you deal with on a day-to-day basis. Do these resonate with all of you? Since so many of you told me this, I'm assuming so, but Okay. So psychology, the workforce. So here we'll kind of move away from you and move more into kind of where you all are working and access to care and issues around the future of the profession and what that means for the state. So just a reminder, 3,800 licensed psychologists in the state, 3,500 reporting a Minnesota address. I want to make sure I always do this, get away from my notes and then forget important points. So, okay, we don't actually know exactly what this means. So somebody could report that they have an address in Hudson, Wisconsin, but they could be making the trek over the border every day to provide services in the metro area. So it's difficult to say which is the right number. We know the upper bound is about 3,800. We also know that of that 3,800 or 3,500, not all of you are actually practicing. Most of you here are probably practicing, but not everybody who maintains a license is still practicing. So just putting it in context, these are all of the licensed mental health professionals. So social workers is the largest group at over 12,000. I should mention, we know that about 60% of social workers are not actually providing direct patient care. So depending on your definition of a mental health worker, I included all of them here, but if you're thinking about the folks that are, kind of sitting one-on-one and providing direct client care, it's only about 60% of that. Then we have psychologists, alcohol and drug counselors, marriage and family therapists at 1,800, professional counselors, that includes the clinical counselors and the licensed professional counselors. Psychiatrists, only 867. And then psychiatric nurses, even smaller than that at 303. So the total, I know you can't read that, the total licensed mental health workforce is just under 24,000. But like I was saying, we know that this is probably a fairly significant overcount once you remove the people that are, maintaining a license here but working out of state, maintaining a license but not actually working, and also those that are maintaining a license but are not working, providing direct client care. Just to put this in context, I thought you might like to know that there are about 90,000 registered nurses working in Minnesota, and there are about 22,000 licensed physicians working in Minnesota. So.
Are you taking questions? The market,
Yes.
the whole market of who receives services and who provides services. I'm very curious about the license to the non-license, and also how many people do each of these serve? Do you have any of that data?
I can answer that. We do, my office does not collect data on non-licensed. That data does exist though. DEED, Department of Employment and Economic Development, collects the data, and we do look at that quite a bit. So it's there to be known. Do we collect information on the people, kind of like caseloads and that sort of thing? We have a few roundabout ways of getting at that, which some of what I'm about to show you will get into that.
I just wondered, when you use the term psychiatric nurse,
Yes.
if you've already started breaking down psychiatric nurse versus something like an advanced practice nurse, which is...
Good question. This number includes all of them. Because APRN is such a new license, we just started collecting data on APRNs, but this number includes everybody. Yeah. Okay. So this is somewhat getting at your question, not exactly directly, but this is just another way to kind of look at the numbers here. And it's the ratio of population to provider. Are folks familiar with looking at this sort of data? I can kind of go into it. So basically what this means is that for every psychiatric nurse, this is statewide, so in Minnesota, every psychiatric nurse there are almost 18,000 people. That's not obviously the number of people that nurse is caring for, but it just gives you a sense, if you compare across it will give you a sense of the relative size of these different professions. But what this is more interesting and helps you, oh, thanks. Yeah, that's good. It helps you to understand better some of the regional kind of maldistribution of people around the state. So this bottom line here, these are the statewide ratios of population to providers. So for example, for every psychiatrist in the state of Minnesota, there are 10,900 people, potentially sharing that one psychiatrist. However, when you look, so I colored in green anything where the ratio is lower than the statewide ratio, and anything in red is higher. So like you can see that in the metro area, I reserve judgment on whether the statewide ratio is what we want, maybe not, but at least in Minneapolis-St. Paul, oh thanks. At least in Minneapolis-St. Paul, we're doing a little bit better than statewide, and of course in Southeast, this is the Mayo effect. We do a little bit better with some of the professions, but looking at central Minnesota, looking at Northeast, the entire western side of the state, rather than 10,000 people needing this, perhaps needing the service of one psychiatrist, you're sharing that one psychiatrist with 4 times the number of people. So it really is a maldistribution of services, and that's one of the things that our office works on quite a bit. The Rural Loan Forgiveness Program runs out of our office. One of the ways, as Angelina mentioned, one of the ways that we talk about solving this problem is through telemedicine. So we ask on our survey, how often do you diagnose or consult with patients in real time using telemedicine equipment or software? And I don't know if you can see that, but 82% of psychologists say they never do. Again, how often do psychologists diagnose or consult with patients in real time using telemedicine equipment or software? 82% said never, they never do it. 12% said occasionally. 3% said frequently, and 2% said all the time. So this is not a lot of folks providing services through telemedicine. I have a feeling there's more here to discuss, and I know this is actually really complicated legally and reimbursement-wise, so maybe we can talk about that a bit more in the afternoon. Okay, just talking a little bit about age. More than half of all psychologists are age 55 and older. And if you look at the distribution, if you can see the distribution, the younger cohorts are proportionately much smaller, which tells me we're not adding in as many of these younger folks. This is probably not news to you. I want to put this in a little context. So the median age of the U.S. workforce is 42. Median age of U.S. psychologists is 46. The median age of the Minnesota workforce is 41. Marriage and family therapists, 45. Social workers, 43. Minnesota psychiatrists, 55. Minnesota psychologists, 57. 57 is the median age. So I actually took a quick look at our most of our other healthcare professions. Psychology is actually the oldest licensed healthcare profession in the state. What share of you are actually, what share of you licensed psychologists are actually still working, still practicing in the field? 94%. That's a very, very high, that's sort of what we think of as our labor force participation rate. That's a very high utilization rate of you guys. This compares to about This compares to about 85% of marriage and family therapists, 91% of social workers, and 92% of physicians. So you guys are, being utilized for sure. Do you have a question?
just a hunch about why the number of psychologists is so much smaller below 55. I think that's about the time that the licensure requirement changed from a master's level to a PhD level.
I was hoping
And that's
somebody
scaring
yeah.
away a few more of the younger potential psychologists.
Yeah, and yeah, I mean, especially if the median wage, which I'd looked up for people who are not in their, don't have their own practice, the median wage for psychologists is about $70,000 a year. So, if you invest in that much education, that's I can understand why people have student loans. So looking at it by age group, I was curious to see 34 of those 34 and younger, almost everybody is working as a psychologist on down. And so if you look at even those age 65 and older, this is when a lot of us are retiring and, going off to the beach and stuff, 87% are still working as psychologists. How much do psychologists work? You work pretty hard. 77% of you say you work full-time and 23% say part-time, and 40 hours is your median work week. Now, looking at ages 65 and older, oh my gosh, almost 50% of people age 65 and older are still working full-time. So I'd love to hear more from you about that, maybe this afternoon. And 30 hours is the median work week. So that's not just, putting in 10 hours here and there. This gets a little bit at the question that was asked earlier about the time of, the share of your time that you spend actually on patient and client care. Only half of you, less than half of you say that you spend more than 75% of your time on patient care. And we ask that question in a really kind of open-ended way. We say, you, professional, you tell us what you think is client care. So for you, that might include paperwork. It might include some travel. It might include appointment scheduling because you know that you have to track these folks down. For others that might not, you tell us what you consider patient care. And so even allowing you to include paperwork and things like that as your patient care, less than half are spending more than 75%. So, though you're working hard, not everyone is seeing patients perhaps as much as you might. But we can talk more about what that means. How long do you plan to continue practicing? 51% of you said more than 10 years. 24% said 6 to 10 more years. And then 26%, so a quarter of your profession plans to work 5 years or less. And of those, 90% of you said that you plan to retire. That makes sense to me. Just providing a little bit of maybe some baseline data to support some of the rest of the conversation later this morning. How often do psychologists provide clinical training or supervision to students or interns? So how much are we kind of bringing these folks along? Almost 40% of you said never. 8% said you do it all the time. 18% said frequently, and 34% said occasionally. I'm just going to end. Our last little bit of data is some supply and demand data that I pulled together from our friends over at the Department of Economic Development. There's a statewide annual market demand. This is a market demand, so not even need. Need, I would imagine, is much greater than market demand, but a market demand for 133 psychologists. We are producing, we produced in 2014 106 PhD level psychologists. So we are not producing psychologists. We're not even, regardless of the post-graduation internship and those sorts of, opportunities for people to be able to enter the field, we're not even producing enough to meet the market demand. And I will actually add that market demand number does not account very well for people working in private practice. It just doesn't count those folks. So this is probably even an undercount. Okay, I'm going to quickly wrap up. give you a couple summary points. So psychologists are the second largest mental health profession in the state. I think you guys, reading through your comments and looking at your data, I think you occupy a very special and kind of unique niche in the mental health workforce. You derive great satisfaction from intellectual challenges and working with clients and seeing them succeed. And you're also, not too surprisingly, stymied by some bureaucratic oversight. This is, by the way, not particular to psychologists. We see this all over with all of our healthcare professionals. You're a group of professionals that are fully utilized. You're mostly working full-time, well into your 60s. We see a maldistribution of professionals across the state. Telemedicine doesn't appear to be a panacea. It's not a clear solution, at least not for now. And postgraduate training opportunities are perhaps not what we'd like to see. The profession is aging, and can Minnesota produce enough new grads to meet the demand or the need? Oh, and that's it. So, Q&A. Thank you.
Thank you, Dr. Fritzma. Now we have an opportunity to talk to Dr. Fritzma a little bit. We do have a mic in the middle there if you're able to come up to the mic. We also have, we'll have some staff members in the audience who can get it to you. I just ask that you make sure that everybody can hear the question so that she can respond. I'll start off just really quick with 3 of the cards. Yep, I'm gonna leave here, so if you wanna come back. Yep. One of the questions is that Dr. Fritzma said psychologists were more satisfied than other fields. Can you tell us what the satisfaction numbers are in other professions that you know of?
Well, so the quick answer is not really. We just fielded this brand new survey, and the satisfaction questions are new on this survey, and so we're seeing some data roll in, and in preparation for this presentation, I took just a really, really quick look. I think I did write down for social workers, for example, which is, maybe a close comparison. I believe that 45% of social workers indicated that they were very satisfied with their career overall, whereas you guys were at 62%. So I think that's the only one I was able to look at, because not all that data is in yet.
Thank you. The next question is, which state passed the SIPAC? Does anyone in the audience know? All right. Arizona was the first state to pass the SIPAC. And just as a reminder, they're single right now. And so until they get a relationship partner, we can't practice into Arizona just yet. We'd have to hook up with them. So we look forward to continuing to have that conversation. The next question it's more of we got a contribution. It says, looks like random client satisfaction might be quite different. Survey by degrees and by license type, and other potential dependent variables. I don't think we look at outcomes enough. Dr. Fritzma, do you have any feedback on outcomes and how that might be?
Outcomes for the patient, or patient outcomes? My group we do not look at patient outcome. We do not survey patients or review patient outcomes, but others in our department, in the Minnesota Department of Health, do. So that would be our health economics program. I tend to agree, though. I mean, we could be looking at outcomes more, and that's something that the Department of Health is really concerned about. Obviously, that's our mission. So,
thank you. Our next question from the audience is, what do you see as psychologists' unique niche? As you know, it's difficult. We have an array of mental health professionals, and it's difficult to explain to a client how psychologists differ from other mental health professionals.
Okay, this is the first year that we've collected data on psychologists, so it's really, truly in the last 2 weeks is the first time that I've had a chance to delve into this profession. But and this is this is gut, not data, which I'm not always comfortable talking about. But reading through your responses for your work satisfaction questions, I got a very clear sense that this is a this is a group of people who are caring and also intellectual. And I think if I had to venture a guess, I think that, and you're focused more on kind of individual outcomes as opposed to, like in social work, we're looking more at kind of how society, how the individual functions in society. And so I think that that's, I think that that's such a valuable perspective to bring to the mental health, to the work of mental health. And I think it would be a huge loss to see those services dwindle in our state.
We have an audience question, and they should have a mic. Go ahead.
Thank you. With regards to the inordinate positive satisfaction of psychologists, I want to throw out a little food for thought. And it's especially related to the context of the fact that one of the main dissatisfaction points was low rate of pay with regards to the extreme student debt. And I wonder whether the positive satisfaction may be reflective of cognitive dissonance. We've put so much in, especially those, younger people coming out with six-figure debt, going through a doctoral program. They're going to be a little bit more apt to want to put their profession in a positive light because of that fact. So,
Yeah.
Any thoughts?
Oh, that's so fascinating. I was listening to, maybe it was some show on NPR about how, they did an experiment where, people had to do these meaningless tasks, like, I don't know, stuffing envelopes or something like that. And for one group, they paid people, and for another group, they did not pay people. Well, guess who was more committed to the task? The people who didn't get paid. And so, that could very well be. I happen to believe that the work that you do is very meaningful and very, would be very satisfying to be able to see people make improvements. So I hope it's not all just cognitive dissonance, but that's a really interesting
Well, the
point.
one thing I'd say with regards to your last comment, I believe those LMFTs, licensed social workers, also see that same
Yes.
fact with regards to the value of their work, but there's a dissonance between our level of satisfaction and theirs, and it could be explained by the great cost it takes on us financially and personally that we need to get there.
That's really interesting. My office is actually planning on doing a broader report on the mental health workforce starting once we get all of our data back, starting this fall. And we'll be looking into that. That's very interesting.
A few more questions from the audience. Regarding telepsychology and Skype, do you have any information on how much psychologists would use telepsychology and Skype?
I wish I did. I was checking with some folks in my office before giving this presentation, and I know there's a difference between the type of equipment that you can use that's dedicated telemedicine, telehealth equipment versus something like Skype or FaceTime and things like that. And so, I actually was hoping you all would provide me with a little bit more insight on how that works for you and how that works with reimbursement and things like that. So maybe, I don't know, maybe others do.
The mic is moving, so I'm waiting for it to stop. Okay, go ahead.
Hi. You present really interesting numbers on the percentage of our career field that's looking at retiring in the next several years, and it looks like we're already starting to slip behind in terms of the demand for psychologists. Have you noticed that trend in other career fields in the past and how they navigated sort of that shortfall, especially as it accelerates?
The answer is complicated. Well, one of the, I guess maybe what I can say is one of the, and I think Mary and Glennis can talk about this a little bit more too. Fortunately, we have people that are actually really looking into this and trying to put some policy teeth into this. But I will say that looking at the numbers, it can be very, very difficult, not so much with psychology, but with other mental health professions. It can be very difficult to document a shortage. It's very easy to document, the need is not being met by looking at things like wait times and, travel times and things like that. And so if the way that decisions get made around post-secondary training and things like that is fairly data-driven, or, oftentimes fairly data-driven. And so if you're looking at demand, it's a little harder to make that case. I think fortunately with mental health, we've been able to make the case. And so, I think later on this morning, we'll talk a little bit more about how that'll work. Did that answer your question?
I think you're getting at it. I think maybe a second part to it would be maybe if documenting a lack is difficult, but documenting the need is easier. Yeah. In other career areas where you've seen this high need and maybe fewer practitioners, I'm thinking about parallel fields. Have you seen what usually happens? Do they let more types of people provide services? Do you see the demand get met in other ways? I guess I'm wondering about other fields that might be parallel to psychology.
Yeah. Yeah, I think this is probably, I think this is going to wind up getting addressed a little bit more with the plan. Team care is an area where I think that's starting to happen a little bit. I'm hoping that you'll talk about some of the peer support specialists and folks like that and those types of solutions to that problem.
Thanks.
Yeah. That's a great question. My office does not, actually, we do not do kind of career outreach. I think that's a piece of, something that could be done. But that does happen in the state. So, other offices, folks over at MnSCU are doing things like that. And actually, the data side of it is happening as well. There's a large effort over at the Office of Higher Education to link student records all the way up from kindergarten all the way on into the labor market. And when our data is actually going to be a part of that. And so we're going to be able to say, well, which type of people are more likely to go into these sorts of fields and what kind of interventions can help them, can encourage them to move into these fields.
Thank you.
So, yeah.
As we're wrapping up our Q&A session, I do have some additional cards. Feel free to write down any more questions and pass them in. We're going to have a half-hour panel session after our second presenter presents. One of the questions focused on the marketing or encouraging people to join the field. I'm excited to share that part of the plan has a goal of recruitment, and we'll be talking more about that in those focus groups. And you'll have the opportunity to perhaps brainstorm and how perhaps the psychologists, as they move towards retirement, could serve as some of those ambassadors for the field, especially with a high level of satisfaction that they might convey to new individuals. So thank you so much, Dr. Fritzma. I'm, again, so pleased to be able to lead this great group and to introduce our next speaker. Mary Rosenthal is the Director of Workforce Development for HealthForce Minnesota. HealthForce Minnesota is one of Minnesota's 8 centers of excellence launched by the Minnesota State College and University System. For the past 2 years, she has spearheaded the legislative charge to develop a statewide mental health workforce development plan. So as Dr. Fritzma talked about psychology and its data, we're now going to get into the meat of what has been done, what is recommended to be done, and then what we might do in the future. Mary came to HealthForce Minnesota from her position as Director of the Service Employees International Union 1199 Northwest Training and Education Fund, a union management Taft-Hartley fund for healthcare workers in the state of Washington. Prior to the training fund, she directed the Phillips and East Metro Health Career Institutes in the Twin Cities, community-based workforce development organizations. She built career ladders for entry-level healthcare workers, created a partnership among employers, a local workforce system, and colleges to support entries into good-paying jobs. Mary will be talking about the workforce plan, and I'm happy to introduce her.
So it's really an honor to be here to talk to you today. I just wanted to add that in addition to a lot of experience that I have with workforce development, and particularly healthcare workforce development, I intimately know the mental health system of Minnesota over the last 42 years. I unfortunately come from a family that has been plagued by plenty of mental health problems, and I just want to thank many of you in this room who have helped numerous of my family members get on to a much, much better place in life. So thank you very much for the work you do. What I wanted to do in today's presentation, and it's going to just go on until 11:30, I'm going to talk pretty fast because I have a lot to go over. But then we have a half hour for a lot more detailed questions and answers. So please, if you can just hold on to your questions, we'll get them at the panel discussion. What I wanted to do today was to follow up on some of the introductory remarks that Angelina Barnes had made about how this workforce plan got developed, its genesis, the public policy, the thinking that went into it. And then I want to go over very specifically the 24 recommendations that were finally agreed upon and where we are in the implementation of those recommendations. So as Angelina said, the legislative charge to develop this workforce plan was Senate File 1236, and it charged the Minnesota State Colleges and Universities to convene a mental health workforce summit, and the purpose was threefold: to develop a plan to increase the number of qualified people working at all levels of our mental health system, to ensure appropriate coursework and training, and to create a more culturally diverse mental health workforce. The legislation also outlined who needed to be involved in the Mental Health Workforce Summit, and it also had $50,000 attached to it. And that's the way that I always know that the legislature is serious about getting something done, is that they attach money to it to actually pay for it getting done. As Angelina told you, Minnesota's, of its 11 areas, 9 of them are considered to be mental health workforce shortage areas. The only areas of the state that are not so designated are the Twin Cities and then areas around Rochester. Because of the Mayo Clinic, and I can tell you from the community forums that we held in the Twin Cities and in Rochester, they think that they ought to be designated shortage areas as well, given what wait times are. 36 other states around the country have mental health workforce development plans. That's one of the reasons that NAMI Minnesota, several of the providers, and the Minnesota Department of Human Services pushed so hard at the legislature. They said this is not going to happen without a concrete plan, without concrete recommendations that are followed up on. We were also, and I just want to lay this out at the beginning, we were asked not to go into the issue of the autism workforce and its needs, or the substance abuse workforce and its needs. And it's not that there aren't big needs, it's not that there isn't a lot of overlap, it was simply that just focusing on the mental health workforce was considered to be a large enough job. We had 18 months to prepare the plan and get it ready. To attach anything else to it was to basically consign it to not being able to be successful. So I want to acknowledge that that is work that continues to need to be done, and that hopefully the work that we did on this plan would help inform creating workforce plans for both the autism workforce as well as the substance abuse workforce. You might ask, why was MNSCU, why was the Minnesota State College and University System given this particular charge? While a number of our universities have social work programs, it's really the private colleges and the University of Minnesota that do a lot of the training and education of mental health professionals. But MNSCU has a wonderful track record in terms of workforce development at all levels. And if you remember the charge of the legislation, it said mental health workforce, not just at the professional level, but at all levels. And we also, and particularly Health Force, has an extraordinary track record as a convener in pulling together a variety of different organizations and making things happen, as you will see. So the genesis of the state plan was taking a look at whether or not Minnesota's mental health force was going to be able to meet the needs of its citizens, particularly with the passage of the Affordable Care Act and the ability now for thousands of more people to be able to access the mental health care that they needed. We have an aging mental health workforce, ongoing discrimination associated with mental illness, and I use the word discrimination rather than stigma because I believe it is discrimination. Low wages, increasing regulations, and the cost of education and training. Little money had gone into any sort of mental health work for the previous decade until the shootings at Sandy Hook in 2014. And I think it was that, as well as the improved economy, and as I said, the passage of the Affordable Care Act, that really set the stage for the 2013 legislation getting passed. And a really big shout out needs to be given to Senator Clausen, who addressed you at the beginning of this conference. Senator Clausen authored and carried the legislation. He attended every one of our steering committee meetings, which was, I think, except one or two when he was in session. And in 2014, really led the push for a lot of the legislation that did get passed to address some of our workforce needs. So he is a true champion of building the kind of mental health workforce that we need in this state. Clearly, workforce was not something that hadn't been looked at before. I don't want people to think that all of a sudden there was 2013 and nobody had taken a look at mental health workforce before. And this just gives you sort of an overview of the last 15 years and some of the mental health work and focus on workforce, but focus on a number of other reforms that have been attempted in the state, and I am sure that many of you have been involved in these efforts. 1999 hearings held by the State Advisory Council, the Mental Health, Minnesota Mental Health Action Group, the Acute Care Needs Subcommittee report, the Workforce Shortage Working Group incentives. What tends to happen in workforce, especially when it's mental health workforce, is that there's so much that needs to get done around mental health and mental health care reform in general that workforce gets put off at the very, very end. So a report is written, a series of hearings are held over the course of 5 days, and it gets to be Friday afternoon, and people finally say, oh, we forgot to talk about workforce. And in point of fact, it's the workforce that is, all of you know this, it's imperative to address that because who's going to deliver the services? So that is part of what led up to this very specific 2013 legislation, was that it had really gotten short shrift. We formed a steering committee that was comprised of all of the stakeholders identified in the legislation. So the Department of Human Services, the Department of Health, the Minnesota State Colleges and Universities, University of Minnesota, private colleges, mental health professionals, special education representatives, child and adult mental health advocates and providers, and community mental health centers. You can see all of that. We tried to make it as representative of the state as possible. We tried to make it as representative of diverse communities in the state as possible. We made this as much of a working group as possible. So we told everybody that we invited to be on the steering committee that we wanted them to meet with us monthly, preferably in person, for 2 hours up to the summit, and then for 2.5 hours to 3 hours after the summit to actually draft the plan. And I want to thank the psychologists particularly who volunteered their time. They were not representatives of your board, but we have Dr. Glennis Edwall, who really played an extraordinarily important role on our steering committee, Dr. Bill Robener, Dr. Alyssa Vang, Dr. Tricia Stark, and Dr. Willie Garrett, who represented the Minnesota Association of Black Psychologists. So really good individual psychologist representation in terms of this steering committee, and I want to thank you all very much. I think that covers the stakeholders who were on the steering committee. The first thing that we did as a steering committee, because none of us had drafted a state plan before, was to try to figure out what was it that we needed. And we knew that we needed a data report. We knew that we had very, very little information on the various mental health professionals in the state. And Dr. Terry Fritzma ended up drafting that data report for us. And all of this information can be found at our website. We've got the entire plan, along with all of the appendices, along with updates on our website in case this isn't enough for you. Dr. Fritzma took a look at the supply and the demand of all of the mental health professionals around the state, broken down by region. What schools are producing how many? Where are these people ending up working? How are they broken down by both race and ethnicity and by gender? And so we had a very good idea of the mental health professionals, but that left a huge swath of people who work with people with mental illnesses who are not professionals. And that is a very, very large part of the mental health workforce. And it was almost impossible for us to really pull out that data. So that is some work that still badly needs to be done. Minnesota is better in its data collection than most states. But I am reminded that we measure what we want to manage and we measure what matters. And to me, the fact that we couldn't pull out a lot of this data on the more entry-level and paraprofessional level of mental health professionals means that, once again, this is just part of the stigma that goes along with mental illness and all of the people who work with people with mental illnesses. So we got the data report. We took a look, as I showed you on the previous slide, of the previous efforts that Minnesota had made. 36 other states had mental health workforce development plans. Some of them were great. Some of them were not so great. We wanted to take a look at what were some of the best ideas that came out. So for example, in New York State Plan, they had a huge problem with Upper New York State. I think something like 90% of the counties in Upper New York State had no psychiatrists or psychiatric APRNs, so nobody who could write a prescription. And so there are a lot of ways to try to tackle this issue. And what New York decided that they wanted to do was that rather than that they would go to the nurses already working in these counties who had their RN or BSN and offer them an online opportunity to get their psychiatric APRN. They developed the program in conjunction with the University of Syracuse, and then they defrayed half the cost of the tuition. So these were nurses who already lived there. They were already committed there. They had their families there. They knew they liked their work. And so it was just a question of beefing up, their skill set. So those were the kinds of things that we wanted to do by taking a look at some of these other state plans. We wanted to get input from all over the state. I used to live in Duluth, and you have no idea how much I resented all the trips I had to make coming down to the Twin Cities rather than the other way around. So Health Force decided that we wanted to hold community forums all around the state to really talk about mental health workforce. So again, as Angelina told you, we went to Worthington, to Rochester, to Bemidji, to the White Earth Indian Reservation, to Duluth, to Wilmer. We really spent about 6 months putting on these 2-hour forums and then really trying to get people to hone in on workforce and to try to generate recommendations about how, what would you like to see happen to your mental health workforce? And this is not easy in a group of people who really want to talk about all of the other problems that are happening in mental health. And there are just a huge number of other problems. So to try to get people to really think about workforce and then not just answer every question about workforce with, we need to increase rates. We need to increase rates. If we increase rates, everything will be taken care of. We wanted to acknowledge, yes, rates need to be increased, but what else? Does that end up taking care of cultural competence? Does that end up taking care of ensuring appropriate education and training? So these were really very directed conversations where we tried to elicit as many recommendations as possible. We knew that a lot of people weren't going to be able to make it to the summit. They weren't going to be able to come to a community forum, so we also had a survey. More than 500 people participated in the survey, giving us some really excellent recommendations, but also some extremely interesting insight, as you saw from Angelina's slide, about how people of color perceive the competence of mental health professionals when it comes to cultural competence compared to white people. So we got a lot of information out of that survey. And then at the tail end of May, we had a summit. Did anybody in this room come to the Mental Health Summit at Hennepin Technical, Glennis? Okay. We very specifically wanted to make sure that it was not overwhelmed by people from the Twin Cities, so we made it, and that it represented all of the various stakeholders. So we did make it by invitation only. It was 150 people, and it was an 8-hour working session. So this was not a conference where people got to sit back and listen. This was a conference where people had to sit at tables and generate recommendations. Recommendations. So the steering committee then met with over 250 different kinds of recommendations from the community forums and from the summit. And we decided, what are the criteria for these recommendations going to be? And we said they have to be actionable. They have to have somebody who is accountable for making them happen. They have to be measurable, and the steering committee has to have consensus on them. So working backwards, we said that we wanted to have consensus because it is so easy in groups to focus on the one thing that they can't agree on and then spend 90% of their time trying to convince people why they're right. And we just said, we're going to put those issues into a parking place because there is so much that needs to get done that surely we can agree on some things that need to get done and then come back and have another summit in another 2 years and tackle those issues. But we really wanted some successes that we could build on. This is an area that's been overlooked for way too long, and it needed some momentum and it needed some success. We also wanted the recommendations to be as concrete as possible. It's one thing to say that we need more diversity in our mental health professional workforce. In California, they defined exactly what that was going to be over a 5-year trajectory. It's going to be increasing the number of African Americans who are enrolled in this program by X% in year 1, by X% in year 2. And when you start being very, very concrete, the steering committee discovered the extent to which a recommendation could actually be done versus one that really couldn't be done. That it's just, we didn't have the time to make it work, or we couldn't figure out concretely when we would know that it had actually succeeded. We also wanted to build in somebody who would drive it. Our experience is that once something is everybody's responsibility, it becomes no one's responsibility and it's not going to get done. So to the extent that we could, we tried to assign each one of our recommendations a driver for that particular recommendation. And as a final thought, there are some things in the delivery of mental health care services in Minnesota that really work, and we were not interested in creating things from scratch if we had some things that worked really well and it was just a question of trying to marshal resources for them. So that was another thing that the steering committee thought about. We took those 250 plus recommendations, and with the help of Dr. Mark Schoenbaum, who specializes in workforce development, we organized them into these big categories of recruitment, education and training, placement after program completion, retention, and then we wanted an assessment. We built in sort of, okay, we've got these recommendations, what works, what doesn't work, and why. And this last part, assessment, was really important to us, particularly as we went around to the community forums. The number of times that people in Bemidji have been called together for a community forum to discuss mental health, to discuss student loans, to discuss this, to discuss that, and plans are written and then they are shelved. And they simply said, we don't want that to happen. We want something that is seriously actionable, and we want you to go back and tell us how well this has worked and how well it hasn't worked. So we built in an assessment component. So I have now got 20 minutes to walk you through the recommendations and how we are faring on them. Everybody okay with that? All right. So, recruitment. How do we expose middle and high school students to mental health careers? And this was a comment that somebody had brought up. And we actually had a number of very, very concrete subsections to this recommendation. Health Force Minnesota runs Scrubs camps. This is a way to introduce middle and high school students to various healthcare careers. And, they for example, we have aging suits, and they put on aging suits, and they discover when you fall down how hard it is to pick yourself up when you're an older person. They type their own blood. They, make sets of dentures or whatever. They have a lot of people from the community, providers as well as teachers, who come in and do these 2-hour classes to introduce people to various careers. We had never had a mental health component until 2 years ago, and we started to bring in a mental health component. We've expanded our Scrubs camps, and so that they are now being offered all over the state of Minnesota in conjunction with either a MNSCU or a private college. And that's one way that we're trying to attract more people to these careers. The school-linked mental health grant recipients, and I think there are about 80 of them, wherever their high schools have a career day, they bring somebody in to talk about mental health careers. And I think that the thing that's tricky about this is, how do you make mental health as a career come alive to a 12-year-old or a 16-year-old? Because if what your job is mostly doing is like talking, and you're up talking to a bunch of people for 40 minutes, and I'm discovering this myself, people sort of start, what's interesting about this, But I mean, so Drexel University offers a 2-week mental health camp introducing people to mental health careers over a 2-week period, and I got in touch with them to talk to them about some of the things that they do. And it's just fascinating. They will hire an actor, and they will have 2 people from the class, and the actor will be somebody who's seeking mental health care, and they'll have 2 people from the class act as professionals, and then they'll have the rest of the class look and try to do, sort of a critique of it. So you really get a sense of not, you're telling me what the work is like, I'm getting the experience of what the work might be like. There are people who bring in various, I know I was up at Bemidji, and the psychology professor actually brought in a couple of her family's pet white rats and had all of the campers do a psychological experiment on these white rats, because research is part of something that people who study, not everybody gets into, counseling. So anyway, we approached the Cultural Providers Network, and we got 12 volunteers of mental health professionals of color who are willing to come and speak at any of the Twin Cities high schools whenever they have a career fair, because we really wanted to have people who look like the people that they're trying to recruit. And I know that Val DeFore, who's the executive director at Health Force, told me that one of the most poignant comments that she got from one of our Scrubs campers after a presentation by a social worker at one of our camps was, "I never knew that social workers did anything but take children away from their families." So there's an incredible opportunity here to reach into these groups of young people and get them really excited about the incredibly important work that you do. There is one effort that I'd like to see tried. I just haven't been able to find a champion at the University of Minnesota, but the University of North Dakota, in conjunction with the Bureau of Indian Affairs, actually runs a psychology summer institute where they bus to a number of different reservations, and they take students who are interested in studying psychology in college, and they bring them to this 2-week camp where they already know that they want to be psychologists, and they beef up their math skills and their science skills so that they can be much, much more successful. And at our summit, we actually got to talk with one of the graduates of that program. Now, something like that takes money, and it takes time, but it has actual concrete results of creating more Native American psychologists to serve the North Dakota population. And it would be very nice if the University of Minnesota would take that on. Improved collection workforce data at all levels. That's something that we're working with Terry Fritzma on. And this one's probably going to be a 5-year project. What we would really like to get is not just the data on mental health professionals, but get the data on psychiatric technicians, get the data on very entry-level workers who are coming out of high school and are playing this role in adult foster care as security counselors at our state hospitals, and really get a count on who is doing what, where, and what are they getting compensated, and what is the education and training that's required for them. So that is a work in progress. Ensure access to and affordability of supervisory hours. This is an enormous issue, not just for mental health professionals, but for all healthcare workers. I think all of you know that providers, whether they're hospitals or clinics, are just getting financially stretched farther and farther. And so their ability to provide either free supervision or any sort of supervision at all is really getting compromised. Senator Clausen had a bill in the Senate. It unfortunately didn't make it into the last budget bill, but that would have expanded these supervisory positions around the state. It's a terrible constriction in the pipeline, and I'm concerned that what has started to happen, at least among social workers, is that they are getting jobs where supervision is not being provided, and they are now having to pay for their own supervision. So you get a Grand Rapids social worker who is graduating with a master's degree, $75,000 in debt, now having to pay for her own supervisory hours, making $38,000 a year. I mean, the shift of the funding is going almost exclusively to the individual, and it really requires us to figure out what sort of a collective action so that everybody's shouldering the cost of this. We talked about getting higher level mental health degree programs in rural areas of the state. Again, Bemidji, they were very, very unhappy with the Twin Cities. You know, the fact that you have to come down to the Twin Cities to get a lot of these advanced degrees means that a lot of people stay in the Twin Cities. We did an informal survey of APR, it wasn't APRNs, I can't remember what profession it was, but the 50% of the people that we surveyed tend to work within 50 miles of the place where they completed school. So being able to figure out how to get education to people right where they're at was just sort of the genius of that New York psychiatric APRN program. You're seeing a lot more online social work programs that are happening, but not as much in the other mental health professions. So this question of how we get mental health care into, parts of greater Minnesota, you can have telemedicine, but it would be really nice to have professionals actually living there and in the community as well. So. Increase by 4 the number of psychiatric residency and fellowship slots in Minnesota over the next 2 years. We managed to get $3 million over the biennium for residency slots. Psychiatric residencies are 4 years, so we're going to have to go back. We're going to have to get more money. But we did get 2 additional residents as a result of this, psychiatric residents as a result of this, so that was nice. Expand and replicate the diversity social work advancement program to additional mental health disciplines like marriage and family therapists, psychologists, and expand practice locations. This is a program that particularly targets social workers, immigrant social workers, and social workers of color at particular times in their program to provide support so that they can make it through their programs. And it's been funded by grants from DHS. It continues to be funded. We really wanted to figure out whether there was a way that this could be expanded to other mental health professionals and around the state. We didn't get as far as DSWAP being a pilot for other professions, but DHS did give a lot of grants that basically accomplished much of the same thing in this last legislative cycle. And I've got a list of what those are for anybody who's interested. Expand the capacity to train certified peer specialists and family peer specialists throughout the state with a particular emphasis on recruitment from communities of color. There's a recent report that just came out February 1st, 2016 about the usefulness of the peer specialist program. How many people are familiar with peer specialists? Okay. It was something that I had no idea about, but it's one of these emerging professions that seems to provide a lot of help for people who are in crisis and to the teams who are working with people in crisis. Support efforts to expand and broaden mental health telemedicine, require commercial health plans to cover services delivered via telehealth technology. $773,000 was appropriated in the 2015 legislative session to help fund that. So it's a beginning. There's going to be a report back in the next legislative session to determine how well that's worked, but it was something that there was a lot of bipartisan support for. Promote a team-based healthcare delivery model for mental health treatment. And you probably know a lot more about this than I do. I was just recently reading about what Sanford Health and Thief River Falls Community are trying to do in terms of filling in the gaps where they've got very, very limited resources, and they're trying to figure out through working collectively how to stretch them as far as they possibly can. Encourage job seeking in high-need areas, add mental health professionals to the eligibility requirements for the Minnesota Health Professionals Loan Forgiveness Program, increase funding, and make sure that 50% of this additional funding be made to mental health professionals from diverse ethnic and/or cultural backgrounds. This was one of the real highlights of the last legislative session. The loan forgiveness program expanded from $740,000 a year to $3.24 million a year. So it more than tripled. And there were the only mental health professionals that could be funded were psychiatrists and psychiatric APRNs. And this has now been expanded to include all mental health professionals in the rural areas, and that it got implemented sort of the third or the fourth quarter of 2016. But there were 4 mental health professionals that were funded in the rural part of the state in 2016, and for next year there are already 25 who are being funded. And in the urban area for 2016 there were 5 funded, and next year they're going to be 9 funded. For loan forgiveness, there are very particular parts of both the Twin Cities and southeastern Minnesota that are designated as shortage areas, just very particular neighborhoods, which is why you see that there's some of these urban grants that are being made. Will Wilson, who runs that program, says that about, I think it's 80% of the people who take advantage of these loans end up staying in their communities. So it is money that is really well spent. Continued funding of the Foreign Trained Healthcare Professionals Grant Program. We got $200,000 to continue that funding. Identify and address gaps in the educational, certification, or licensing systems that impede career movement from entry-level paraprofessional positions to terminal degrees and licensure as an independent professional. This is being tried in some places like Philadelphia, where they have a consortium of hospitals, and you will have somebody who's worked in a hospital or a clinic as a paraprofessional, maybe with just 1 year of college, but loves working, just loves this work, is very, very familiar with it, and trying to figure out how somebody like that can move up a career ladder and get a master's degree and become a professional is something that we've actually been able to figure out how to do in the nursing professions, from a nursing assistant to an LPN to an RN. I don't know that I've ever seen any profession where the gap between a very entry-level worker and the next step is quite as big as it is in mental health. So you can be a security counselor at St. Peter with a high school degree, and you get some, internal training, and then the next step is a bachelor's degree in psychology. And there's really sort of like nothing in between. So one of the things that we're really trying to figure out is what might that be? And we've been doing a lot of interviewing of employers to try to figure out what are the skill sets that maybe a 2-year degree could accommodate and embrace that maybe the 4-year psychology degree doesn't go after. And then how do you provide financing and the training and the employer buy-in to make that kind of thing happen? We're really trying to figure out how to address this shortfall in the mental health workforce in all ways possible. Increase reimbursement rates. DHS has already posted an RFP for a study, and I think the results on that are going to be out at the end of this year. I'm going to go very quickly, and then assess the recommendations. So July of 2017, hopefully we will have another summit, and we will assess the recommendations. Now, the ones that have yet to be implemented, I talked about the Indians in Psychology Doctoral Education Program, not implemented. We asked for $500,000 to pilot Project Lead the Way Biomedical Science Curriculum in 10 schools in Minnesota as a way to try to get more people interested in science, and from there to mental health. That's going to be introduced next year. We couldn't find a House sponsor. require third-party payers and commercial insurers to reimburse in the same way medical assistance does for supervision and internships so that services provided by mental health trainees under the supervision of mental health professionals are reimbursable. That did not go anywhere. So this is like your work. This is what you get to discuss this afternoon, how you're going to make that go somewhere. Develop a faculty fellowship model to engage faculty in the newest understanding and treatment of mental illness in both children, youth, adults, and older adults. So 42 years ago, when my brother was diagnosed with very, very serious schizophrenia, it was basically sort of a lost cause. And I remember the doctors at the Mayo Clinic just saying, it was just heartbreaking, for my parents. Other members of my family more recently have been diagnosed with schizophrenia, and the message that they are getting is totally different. It's recovery. And we've just got to make sure that the education and teaching that we are providing to people, whether it's at the continuing education level or our new graduates, really understand that this focus on recovery is absolutely critical. Charge the Department of Human Services with establishing a criteria and payment mechanism to incentivize mental health settings committed to providing students with a practicum experience that features evidence-based treatment interventions. Again, that's something that we're going to try to focus on and get established. Improve and expand cultural competence training, establish cultural awareness as a core behavioral health education and training requirement for all licensure and certification disciplines. I will tell you that this was the hardest recommendation. We had a lot of specifics attached to it, and it always ended up being the very last thing discussed in our community forums. It was the last recommendation addressed by our steering committee. This is not going away, and we really need to figure out how to be very concrete in what we want and how to provide the resources to make this happen. The most concrete that we could get is that a variety of organizations would hold a cultural competence summit to showcase best practices in the promotion of cultural competence in delivering mental health care services and provide access to education and training resources. But all I can say is that when you have a survey that shows that level of discrepancy between what people of color want and what people who are white think that we need, that's a real disconnect that I think that it's important to try to figure out how to address and then how to measure whether the way that we're addressing it is actually making a difference. Increase exposure to psychiatric mental health experiences for nursing and medical school students. This is really, getting at this idea that a lot of mental health diagnoses are made by primary care doctors or are seen by nurses, and they need to know a lot more about mental health. And unfortunately, what we are finding is that in some of our nursing programs, it's the mental health residency over 2-3 days that is being booted off in favor of other things so that our nurses aren't even getting that experience. And so we need to change that. Utilize accreditation council. This is another way to try to expand access and program funding by utilizing the ACGME and APA standards for psychiatry residency and accredited psychology internship programs. We'll talk more about that. Provide support so that all psychology internships at state institutions are accredited by the APA. There are 2 of them that are run by state institutions that are not accredited by the APA. We asked for $50,000 from the legislature because this is really a question of money and resources that these programs need, and we couldn't get that money. There are other non-accredited APA internship programs that are running in the state, but these are 2 that actually are run by the state, and we need to address that. Unfortunately, you also need to keep Anoka Hospital open, and so there are priorities, right? Department of Health will evaluate Merck funding as a way of getting more money into training sites. We didn't get any money for that. Ways that technology can be used to streamline paperwork and ensure necessary data capture. We are pushing DHS to try to fund some pilots over and over and over again. From everybody we heard, the paperwork is killing us. So I don't think that the paperwork is going to go away, but what are some creative ways that paperwork that can be done so that it isn't so all-time consuming and seen as being really sort of outside the work. Okay, I think what we're going to be discussing is, on the recommendations, is what worked and why, what didn't work and why, and what should be included in Summit 2.0. And I think that's a nice segue into what you're going to be talking about at 1:15. So thank you very much.
Thank you so much.
Now that we've heard a little bit about psychology itself and we've heard about the mental health workforce plan, we'd like to take about 25 minutes and have a panel discussion with our two presenters. Mary Reagan was originally going to join us on the panel and was unable to do so. We regret her not coming, but it resulted in a very nice gift as well. And I have to tell you, I begged, I pleaded, I asked 5 minutes before we started. And so with that disclaimer, we are lucky to have Glennis Ebwall here, who is going to join our panel discussion. Glennis has a PhD from the University of Minnesota in educational psychology. She also has a PsyD at the University of Denver in child and family focus. She's an associate professor, director of clinical training, Baylor University from 1986 to 1991. University of Minnesota Health Psychology Program and the Department of Pediatrics from 1991 to 1993. Her responsibilities there included supervising interns and postdocs. She was a psychology services supervisor at Children's Hospital in Minneapolis from 1993 to 1996. She was also the director of the Fraser Child and Family Center in Minneapolis from 1996 to 2000. She was the director of the Children's Mental Health 2000 to 2013, and the Children's and Adult Mental Health departments from Minnesota Department of Human Services from 2013 to 2015. This position including participating in the Workforce Development Plan. So that's how she got integrated very closely with the creation of this plan. Glennis has retired in 2015, or she thought she did, until we pulled her out here. So she's currently consulting, supervising postdocs, and serving as an accreditation site visitor for APA. So let's thank her and Dr. Fritzma and Mary Rosenthal as we go into the panel. We also have with us today on the panel Valerie Dufour, and somebody sniped up my notes. Give me 1 second.
Okay, I can.
You want to do it?
I can give a 2-sentence.
Come do it for us.
Oh, you got it right there.
I'm Valerie DeFore with Health Force Minnesota. I'm the executive director, and I think you all are all probably feeling the same thing I am in how lucky am I to have Mary Rosenthal on my team and to have led this work for us. But that's what we've been doing a lot of for the last 2 years. My background is actually, I've been doing this type of workforce development work for the Minnesota State Colleges and Universities since 2001. Prior to that, I was in healthcare consulting for about 10 years with a master's in healthcare administration from Arizona State University. Thank you. Good enough.
Excellent. Thanks so much. I appreciate it. If we could have all the panelists come up and join us at the panelist table, please, so we can get started. And I'm going to give this microphone back to Mr. Campero so that he can give it to you. We'll start off with some of the card questions that we haven't gotten to yet and that have been submitted, and then we can also take questions from the audience as we go on. I've always wanted to be like a game show host. All right. The first question is for Dr. Fritzma for 5 points. Can you discuss or describe the non-practitioner roles of psychologists who responded to your survey? Settings, trends, differential levels of satisfaction compared to practitioners?
Okay, in my defense, starting off. So actually, no, I cannot. And the reason is that we just fielded the survey at the end of April, and I pulled out the, the data at about May 5th. So I've been furiously analyzing the results just for the purposes of this conference and kind of making sure that we've got all those T's crossed and I's dotted. So, but actually, if you could read that again, that'll give me some good ideas for future analyses.
Would you like the card?
Yeah, that'd be great.
All right, next up, we'll start with Valerie Dufour. Having a more diverse workforce is absolutely necessary. Minnesota has a high rates of segregation and access to care, and it seems there's more to it. Some data suggest that people of color, perceive psychology as a white profession. What are some ideas for expanding care models that are inclusive of a variety of cultural conceptions of mental health? And obviously others can chime in too if they want to. Yep.
Well, and I think, actually Mary covered, a little bit of that as we discussed it in the development of the mental health workforce plan, and how we were just so intentional in kind of engaging in having that discussion around cultural, racial, ethnic diversity and cultural competency. It's a challenge not only, it's across all of our healthcare occupations and disciplines. We know empirically, and I say this a lot, that it makes a difference in patient outcomes when the healthcare providers look like the patients they serve. So we are dealing with this with our nursing programs, with clinical laboratory, with any of our healthcare programs, and I'm sure all the employers in any of their occupations. One thing, I guess, just thinking more practically about a response, I have personally worked with one of our federally qualified health centers, the Open Door Health Center in Mankato. I was their board chair for 6 years and really got to see kind of firsthand what it meant to provide a welcoming environment and to have care providers, interpreters, translated material, and all of that available to, in Mankato, we served a lot of Somali and Hmong patients. So, I think it goes kind of hand in hand. We have to do our work in education with recruitment, with support, with assisting students, and then on the employment side, there has to be that welcoming environment. There has to be a situation where you're perceived as equal, as part of the team. You play that important role. So I feel like that's kind of a world peace question, but it's very important, and I think there's a lot of opportunities. It's just kind of done individually oftentimes. Yeah, Mary.
Yeah, if I could just add, Dr. Willie Garrett made some really interesting comments about this in terms of when he went through his program, that he didn't necessarily get help from other African American, professors, or that it was a white professor who was actually able to run interference for him, but it was just knowing that there was some actual support. And I think that this doesn't happen sort of like automatically. I mean, it's a conscious and deliberate reservation of resources that could go someplace else, that you are saying, no, it's going to go here. I was down at Roosevelt University. My daughter-in-law just graduated with a PsyD, and I was taking a look at the Roosevelt graduating class in her department, and it was like, it's like 60% people of color, and that is a very conscious, deliberate move on the part of Roosevelt University in terms of who they're going to recruit and how they're going to support those students and what the faculty is going to do. And so I just, I think that where it happens, you can see that it works, and where it doesn't happen, I say, people don't think that it's important that it happen.
One thing I might just add, Mary talked a little bit about our Scrubs Camp and some of that outreach to our, for pipeline development in middle and high school students. Yesterday, we had about 240 Girl Scouts at 3 of our MNSCU campuses. We had 120, 150, and 40 at RCTC, North Hennepin, and South Central in Mankato. And they were through a partnership that we're doing with a special program that the Girl Scouts has in place for high school student girls of racial or ethnic diverse backgrounds or on free and reduced lunch. And so it was a day spent learning about health careers. And we had a session on, it was more related to stress and mindfulness. So it wasn't, hardcore, a mental health occupation that was kind of shared with them at North Hennepin. But that's the starting point, on our end, is really just even increasing the exposure in the pool. And those girls loved that day on campus. Some of them wouldn't have been on a campus. They got to sort of envision themselves, walking the corridors and feeling like they were taking a class. And, I think with the Girl Scouts partnership, they'll continue to support those dreams, and we'll do what we can too.
Maybe just a couple of...
May I ask a question from the floor
Sure.
or a comment? Just as I have been frustrated over the years when people talk about the mentally ill, there's a schizophrenic, there's a person with Alzheimer's. It torpedoes the conversation by using that. And my feeling is with a culturally diverse populations, it's people of color. There is a Somali who is first generation, very different. I, in the work that I did before I retired, used to get interpreters. I had a Spanish-speaking interpreter who, when we got with the patient, said, well, he's from Cuba. I'm Mexican. I don't even understand the language he's speaking. So I guess I'm wondering, is there a way to frame the conversation that gets around the generic thing? It's not skin color, it's very frustrating because I don't see how one can make progress unless we reconceptualize it enough.
Yeah.
So let's have the summit.
Yeah.
Let's
Well,
have
and
the
that
board
is part of
spearhead
that
the summit,
recommendation.
the
Yeah.
cultural
And I know,
competence
Glynis,
summit.
you wanted to pipe in, but if I could just follow up on that. I held, it was the first ever MnSCU nursing faculty conference, and we called it the Inclusivity in Healthcare. And it was about supporting students, and in our minds, it was diverse students. It was a wonderful day. I had about 100 people. We learned from each other. It was a great day. Everybody felt really positive. At the very end of the day, one of our employer partners who was at the conference, who is herself African American, she just stood up and so respectfully and eloquently stated, you know what, this was a great day. She appreciated it. It was wonderful. Most of the conversation steered towards how do we support immigrant and refugee students, and that leads to English as a second language and medical terminology and the stumbling blocks and all of that. She said, that's because that's an easy conversation for us to have. We didn't talk about, and the nomenclature is so hard to, not stumble over, but we didn't talk about Native African Americans who live all around us and have been in this country for 200 years, and that's getting at, bias and racism and prejudice, and so just we have carried that learning and that message forward in our thinking and in our work, but it was really important for her to call that out, I think, and I just share that because I think that might happen often when we try to tackle this.
Well, I appreciate actually thinking about that as a focus, perhaps, for a summit too, because it was such an important part of the legislation and of the considerations. But it's clearly the most important area going forward, I think, for continued examination. I just wanted to offer before Dr. Long's comment that actually as a profession and doing a lot of accreditation site visits, I'm really pleased to see what the next generation, how the next generation is being trained with regard to the standards in both graduate programs and internships around individual and cultural diversity that really do push it down another level, and exactly what you're talking about. But that's late in the game with regard to actually developing a really diverse workforce. And so all of the kinds of learnings perhaps that we have gathered in graduate education, we need to start now scratching our heads about how do we apply that to these concepts of pipeline and ladders so that we're also really attracting people to the profession who represent those communities, represent and come from communities and would go back to those communities to serve as well.
If I could I just make one more comment about that? I've done a lot of thinking about cultural competence, especially because at the Department of Health, we do measure, we measure the diversity of the workforce, and kind of, by default, we compare the race of the provider to the race of the population, and if we're off, then we say, oh, we got a problem here. And I think, the more I thought about that, the more I think it's really so much more nuanced than that. I think, for example, by the time someone becomes a physician or a psychologist or that sort of thing, I think you're not just, you may look physically like the person that you are serving, but you come from a completely different socioeconomic status. So can you really be expected to provide that culturally competent care that we're kind of thinking of when we just match people by race? So I love the idea of a summit. I really hope we do it, and I hope we give some serious thought to some of the nuances around the issue. It's not so straightforward.
All right. Sticking with cultural competence just for one more of these questions here. In terms of cultural competence, we heard some of the efforts that are being done by MNSCU and some of the offerings. However, this particular question speaks to the perspectives of some of those groups, and we've heard a little bit about that from the rural farmer comment and from some other individuals about what diversity might mean. So you said African Americans have a different perspective of white versus African American mental health professionals. Can you talk a little bit about their perceptions? I think they were saying that the African American mental health professionals differed in the slide I had up, that they differed in how white mental health professionals viewed cultural competence. And do you know what the perspectives were of that minority group?
I think you said, Mary, something about the perceptions of the therapist. Let's see, African Americans perceive their therapist differently if they were African American or if they were Caucasian.
Okay.
Oh, I'm sorry if that's what you heard. I think that what I was referring to was the survey results that we did about cultural competence. And there was a question that we asked about in what areas do you feel that mental health professionals should get more training? And there were a list of things that they could check, and one of them was more training in cultural competence. And when we disaggregated those responses, we saw that only 38% of whites felt that there ought to be more training in cultural competence versus the 74% in people of color. So there's just this big disconnect in how white people perceive themselves versus needing training, or white people feeling that mental health professionals need training versus people of color. And again, this was not broken down, sir, but by specific ethnicity. I'm sorry, I didn't make that clear.
Just give 1 second.
Hi, my name is Tanchel Nguyen Kelly, a psychologist from St. Peter. I would like to add some comment in terms of cultural competence training. And I'm definitely glad that will be the topic of the next summit. However, I want to add to it is that from the hiring, recruitment to retention, the focus is really have to be intentional. I know that there is some gray issues in terms of EEO, but we have really to have a comparison with the population we are serving. Whatever the population that being served in that area or in that setting, the recruitment and retention should be focused based on it. Now, coming back to the internship or postdoc training program, I have been always thinking that often the programs only offer separate, like the cultural competence training per se, instead of integrating the cultural competence concept across all curriculum, not just one topic, not just one class, one course, but everything from all presentation on training, the cultural competence concept should be incorporated. I can give an example in the psychology department at St. Peter where I ran is that with the support of the Board of Psychology, we were able to incorporate in own didactic training for internship program and postdoc program. Anything in all didactic it should have mentioned about cultural competence issue, because I'm really worried about the skills, not just awareness. Thank you.
Thank you.
Could I ask a question?
If we could just, we do have a whole stack here, so I just want to jump gears a little bit out of cultural competence. We haven't touched any of the other areas that some of the people were asking about. So we do have a short period of time, but we'll definitely be digging into these issues in cultural competence when we get into our focus group, so there'll be a lot of time to talk about those. So one of the questions, changing over to recruitment, is what two recommendations in the area of recruitment have been most effective thus far?
Well, I'm just thinking that, we launched these recommendations, we presented these recommendations to the legislature in just January of 2015. And so it's a little early to be able to kind of track anything that we've done and has it made, a difference. I'd like to give it at least, another year. As I've said, this isn't recruitment, but I would definitely say that what we saw by putting all of that money into retention, or into the Minnesota Loan Forgiveness Program, you can see that that may make a very big difference if we take a look 4 or 5 years down the road and we take a look at, how many professionals are now, serving areas of Minnesota that weren't served before. But I think it's just a little too early. What I will say is that, though, these young people, they are just thirsty for information about mental health careers. They are so curious. So trying to figure out how to get people really alive. I mean, I'm interested because a lot of people I run into who are like at the Augsburg social work department, or they're in master's degree programs, they're there because the ones that I've talked to, they have a family member who has been suffering from a mental illness, or they had a family member who, for example, worked for a mental health provider. I mean, there's a lot of like personal connection. But the largest major, I think, in Minnesota of all of our colleges is psychology. So people are very, very curious about this.
The evidence that people stay where they are trained ought to really give us some pause about our paucity of accredited internship programs in psychology in this state, and that certainly is an area where collectively we have work to do.
So what we want to do this afternoon sort of has a very specific goal, and we wanted ultimately, kind of in just general terms, we want to be able to take the feedback that we get in these groups and put it to action. We want to share it with the Health Force Minnesota group, and we actually want psychologists to play into how these recommendations come out. I didn't originally have the opportunity to attend the summit, and so one of the things I recognized when we started meeting, all of the 4 executive directors started meeting from the mental health boards with Dr. Fritzma and Mary Rosenthal, I realized that these recommendations, some of them very closely play into a lot of primary issues that we're already looking at as psychologists and as a board, and that we needed to have this conversation. So I'm really excited that we have everybody here to do that. And so just to get us started, ultimately, like I said, we're going to go from 1:15 to 3:15, but our goal is to gather some responses to some focus questions and have a discussion. And we're going to retain that information here. All right. If we could come back together to reach the end. If I could have the representatives of the other groups, the individuals, our facilitators, who are going to present their focus group findings, come up to the front. Number 1 is here. Number 2 arrived. Oh. Yes, please, come on up. Where's number 3? Number 3? Oh. Number 3 has left the building. Well, if number 3 comes along, we'll have them report as well. I want to start off by thanking everybody for staying through the session, for providing that feedback, those comments. I'm blown away by the suggestions, the feedback, the input, the thoughtfulness at ways that we can come on to some of these issues and ways that we can approach them, and at how many of them overlap and how they do support each other, and things that both the board can do and the state can do. So thank you. As we jump in here, we're going to have each of the groups, through their facilitator, report on just some key points from their discussions and what some of those primary were. And being number one, we'll go first. Yeah, see, I got the mic. So in terms of group number 1, we had a very robust discussion, kept me running with the mic, so it was great. I got a lot of exercise. One of the things I heard as a reoccurring theme and what I see in the notes is prevention. This group, we talked a lot about prevention, about getting into educational settings, training sessions, starting young, one of the suggestions was getting into the kindergartens and teaching some of these social, emotional, interpersonal skills at a very young age, get them recognizing that, which could work to destigmatize mental health as well as start before it's developed long on the road, and also to move away from just having your first mental health contact be based on a diagnosis or some sort of crisis issue, but that it starts early and that it's all an integrated part of health. I also heard a lot about primary care and having integrated care and how care is provided. That integrated care would go a long ways towards destigmatizing mental health. It needs to reach actual parity with physical health. If individuals, one of the comments that really struck me was about walking into that building and going there and sitting and sharing a waiting room with people who could be there for any head to toe purpose, as opposed to sitting in the mental health or at the counselor's office, and what that might do for mental health and the stigmas. We heard some suggestions for board improvement and for things that the board might support or do. One of those things is about being a resource and continuing to offer education, be proactive, help people and support people with training, specialized training. And we definitely do that. You can request that at any time, and we'll see what we can do to work that out. The other thing in the board bucket was fees. We talked a lot about expense, getting licensed as an expense, what the board's budget is, and that was an engaging issue. The message I got was doing a better job at educating our own licensees as to what funds the board and how does it run and where do the fees go and what is it giving you. Number one, it's giving you this event as part of it, but it's doing so many more things. And as we're asked to be that resource and to make those changes and priorities, fees do play a role in that. And so we want to make it less expensive, but we want to do that also in a responsible way so that we can continue to meet those needs. Also, necessity of the postdoc. We talked about the postdoctoral experience and is it necessary? What is it doing? Is it adding value? Should it be there? Should it be integrated into education? And there were lots of thoughts about that, lots of sort of drive to see why we have it, be evidence-based about why we have it. And the last sort of general point is getting people employed quicker, getting them into working and being able to see patients, and a lot of it came back to money. You know, what's reimbursable? We learned that teleservices or telepsychology or telemedical services are beginning on the reimbursement track, and that's a necessity in order to make it possible. And then some questions were asked around the SIPAC and what Minnesota can do to provide guidance and take action towards getting telepsychology in place.
Group number two, I think group number two was probably the best group. We had a really good freewheeling but focused when it needed to be discussion. It was a really good way to spend a couple hours. A few of the things that came up for us, one of them was the issue of culture came up in a number of different ways, both in terms of cultural competence and in recruiting people from the non-majority culture into the profession. And when we talked about cultural competence, we really came around to a point of view that what's important is to bring a particular stance to working with people from different cultures rather than focusing on learning content, and really to take a stance that acknowledges whatever privilege that you might have that comes in with some humility and is an extension of our general clinical skills. We talked about recruiting people from different cultures and had some discussion about the way that that intersects with the cost of graduate education. So if you're going to take on $150,000 worth of debt and make $70,000, that is much easier for you to do if you're from a middle-class family and have some backup support. And so that's going to be an impediment, and there's not a real obvious and easy solution to that doesn't cost a lot of money. We talked about our professional identity, and we were really aware that the recommendations go across mental health professions with those of the other mental health professions and sometimes don't, and that we do have a unique identity. And the way our group thought about that was really our training in science and critical thinking as a big part of that. It came up a lot in the, one of the last questions was about supervision and the particular recommendations about cross-discipline supervision and reducing the hours that you, essentially reducing the hours that you would need in order to be licensed. And so we started by kind of rolling our eyes and being horrified by it. But we also took into account the fact that the cross-discipline supervision could be a good opportunity for psychologists. Not in psychologists being supervised by other professions, but a role that we might be able to take in supervising social workers, LMFTs, other professionals as appropriate. And that seemed especially important given that, as we learned from the slide earlier today, we're really, really old. And people are moving into doing different kinds of things with their professional life than direct service. And so that was a way that those two questions and findings kind of intersected. We talked a little bit about the, service delivery to underserved areas, underserved populations, and the potential use of technology to help with that, and the SIPAC that Angelina mentioned. And we also talked about service delivery models that are outside of the box, either technologically or otherwise. So, there are suicide prevention services that are using texting as a primary means of communication. There's in-home therapy, there's services delivered in schools, those kinds of things. And so really thinking about service delivery methods as a partial solution to the underserved populations. So Rachel may have a little bit to add to my observations, and I'll let her take it from here.
So the only other thing that I have listed here, you've touched on every other one so far, is the impact of media and social media. How mental health, say 20 years ago, was almost a very touchy topic to even mention, where now you see some celebrities even talking about bipolar disorder and things like that, where more people can relate to that. Our group talked a lot about that and more of the openness on how people are feeling more comfortable that other individuals that are more in the limelight are coming out and being more open about those topics when they are a little touchy. So that was a big topic and it was great to chat about. So, and that's about it for group 2.
All right.
So in regards to the first question and kind of prioritizing which areas we need to focus on first in terms of the plan, folks felt that, first of all, a good thing that retention is not necessarily an issue for psychologists because we are a happy lot that like our profession. But like every good psychologist, we feel like we need to have a good assessment of what the problem is before we can dive into interventions. And so that was a common theme. Folks also felt that recruitment is where it starts, and then there's also certainly opportunities at education and training opportunities to do more. But without knowing the problem, we really would be hesitant to have real specific recommendations. There is also talk at looking at, we looked at the data of licensed professionals, but there's a lot of individuals out there that are practicing at bachelor's levels in ARMS and in other disciplines, and we would want to better understand that workforce too going forward. A theme in our group was reimbursement issues, and that there is not good reimbursement for folks who have done a lot of education and are practicing as interns or fellows, and that they incur an incredible amount of debt, much more so than folks who have master's degrees, and so that doing more there to reimburse them is important. Similarly, there is not a lot of incentives for supervisors to do this work because there is not payment behind their supervision, and therefore expanding the supervisory field would need to include having more psychologists being paid for that. There was a discussion around supervision, and there was a lot of views. It's nice to have more diversity in terms of other disciplines contributing to supervision. At the same time, there is a socialization process into the field of psychology that only psychologists can do. And there are a lot of roles that psychologists play that only psychologists truly can supervise, whether it be assessment, research, or interpreting research findings. And certain roles we talked about, even from a legal standpoint, things like placing holds are things that psychologists do that not all mid-level providers can do. The theme that came up was very similar to Group 2's, that psychology is really having somewhat of an identity crisis right now, and that came up many times. That there isn't a good understanding of how psychologists is different than other mid-level providers, and that as a profession, more needs to be done to help the public and help others in mental health just be able to understand the different role that we play. And there was a lot of thoughts that, for students who are looking at a profession in mental health, why would they go into psychology if psychology is being lumped in with other professions and not seen as unique given the expense and the time that goes into earning a PhD or PsyD? There was also discussion around paperwork and bureaucracy, third-party payers, a lot of the themes that came out in the survey, and how that impedes people's ability to actually do work with patients, and so that being a barrier as well. In talking about the aging population, we have an incredible wealth of expertise that we could tap into, but again, everyone is very constrained by financial responsibilities, but certainly supervision and other areas of consultation would be something that our older psychologists could play in the field, and that we're seeing many of them in administration positions as well. As we look at different changes to how supervision is done, there was the viewpoint that some of these potential recommendations that are being considered conflict with accrediting agencies. So regardless of kind of where people fell on the issues, that it also might lead to accrediting problems for institutions and internships. And let's see, I also, in regards to stigma, our group talked about how more needs to be done to decrease stigma, because when the populations we serve are stigmatized, it also leads people to be less inclined to go into this profession and to be devalued in the work that they provide to these stigmatized populations. Rural communities, just one other comment on that was that there are a lot of challenges to working in rural communities, and that especially in terms of trying to work through bureaucracy with third-party payers who like to contract with large organizations and not private parties, that can be especially challenging. And resources for their clients are especially sparse in those areas. What did I miss, Leo?
As the other facilitator of what now has been established as the best group. No, that's very good. Two things that resonated with me when we talked about rural areas was the issue of transportation.
Yes.
I think that was a very practical suggestion. How sometimes the issue is not necessarily that the person don't want to seek out help, but that they just don't have the means to get to where the provider is, or vice versa. And so that was a very practical suggestion that I thought was very useful. And another comment that I was very surprised about was the using telepsychology or electronic means to provide services, which my formal educational background is in IT, so I'm a big proponent of technology. But then the person was making the comment that, yeah, given no other choice, that is a good choice, but at some point, it is important to see the person face to face, being in the same room, and I thought that there was very valuable insight in that too as well. So, thank you.
I did miss two things that I think are really important to mention for our group to represent us well. We also talked about cultural humility. We were told and discussed and really dug into the idea that perhaps it's not cultural competency, but what about the concept of cultural humility? Recognizing that you're different and they're different, and I'm not going to do it justice because I'm a lawyer and not a psychologist, but Ann Williams-Wengard did a very nice job at explaining to that, and we spent a lot of time on that and kind of reframing what it means and what culture is, from city to urban to rural, and various different ways in which you can be competent, from the island of Hawaii to various other ways of life. And the last part, which I thought was another really neat coupling, was taking that cultural piece. So perhaps we better connect with the communities and seek these representatives of different levels of diversity. And perhaps we put together a training video or some sort of memorialized representation of information on all of the, well, we'll never hit all, but a fair representative of those various areas of cultural knowledge that these communities and people and different walks of life have to share, and how we can use that as a training resource. And when asked about the seminar, that I really liked that response. Our group one of our members was really quick to say, well, out of everything we've talked about, coming to the job fair or the seminar doesn't seem like, if you had to pick, wouldn't be the high priority. But we did return to that in where psychologists would be willing to participate, perhaps gathering that institutional knowledge or that field knowledge, and again, using a video or an electronic means to share that with our lower education levels in terms of high school, undergrad, telling them, yeah, you might like psychology. A lot of people think it's going to be interesting, but where can you go? Where can psychology take you, and why would you want to do this? So have a great day, and thanks again.